Hi, thanks for watching this video. So this lecture is meant to be paired with the simulation session, and it's meant to give you an introduction to kind of the basic management of a lot of anesthesia situations and how we think in anesthesiology. So first we're going to go over what anesthesia actually is, and the kind of two big components: keeping people asleep and comfortable and all those things, and keeping people alive. And as you can see here, the keeping people alive is a little longer of a list. So a pretty common response that we get when we introduce ourselves as the anesthesiologist is, "Oh, you're the person who puts me to sleep," right? Which is true. Yes, we're the person who pushes the drugs, turns those drugs on. But you don't need to be a physician necessarily to push a syringe of propofol. It's not that complicated. And there are cases where we do anesthesia sedation type things where you don't actually need a physician involved, like a nurse sedation. And it comes down to this balance between a lot of the drugs that we do to keep you comfortable end up being things that also kill you. Like most of our, comfy drugs like opiates also slow your breathing and make you hemodynamically unstable. And those things we need to be able to manage. So whenever we have to give you enough drugs that you become unstable, that's when an anesthesiologist really needs to be managing things. Also, when we're doing these surgeries, the surgeon is actively trying to kill you. And so we try to stop that. Now, the first thing I want to talk about is what I call the dimensions of anesthesia. And basically, you can think of there are several independent things that we're trying to accomplish when we do an anesthetic. And a lot of times we lump them together as kind of one big thing, but they're actually independent of each other. For example, anesthesia, by which I mean unconsciousness, amnesia, not remembering things, analgesia, not having a sympathetic response, not feeling pain if you're awake, and paralysis, not moving. Now, a lot of times we kind of think of these things as, oh, you're unconscious, therefore you're not remembering anything, but you actually can remember things when you're unconscious. You might experience this when you're dreaming, for example, and you hear things in the background. Even though you're externally unconscious, you'll still remember things. Conversely, you can be awake and not remember anything. If you have a lot of benzos or alcohol on board, you can not remember things even though you're wide awake. You can have a sympathetic response even though you're unconscious. You can move even though you're unconscious. So all these things are kind of independent dimensions that we give certain drugs for. A lot of our drugs hit overlapping areas of these. And so if you give one drug in a huge dose, that might hit a lot of these. But that's kind of, a sloppy anesthetic. So what we tend to do is we pick the drugs that are best at each of these attributes that we want, and we titrate it in to just that amount. And that's what we call a balanced anesthetic. We try and pick everything to balance out. It's just the perfect anesthetic that we want. So for example, unconsciousness. What are the common drugs we use for unconsciousness? The drug that most people think of off the bat is propofol. That's, like I just said, that's the drug we push almost every case IV to put someone to sleep. But we don't usually run a drip of propofol through the case, right? How do we keep people asleep through the case? That's our volatile anesthetic, right? So volatile anesthetics, propofol, those are really common drugs that we use to put people to sleep, to keep people asleep. Occasionally, one of the downsides to propofol and most of our drugs is that it drops your blood pressure. So occasionally there are kind of two go-tos that we throw in there instead of propofol if we want to not have as much of a hemodynamic hit. And those are usually ketamine and etomidate. We also use ketamine in lower doses for analgesia. So don't confuse the two. At higher doses, like hundreds of milligrams, we put people to sleep with it. At lower doses, tens of milligrams, we use it for pain. So then what about these other dimensions of anesthesia? Amnesia. We have one drug that's really good at that. Our benzos, so like midazolam, for example, a lot of times we'll give for anxiolysis along with amnesia. Analgesia, one class of drugs we use predominates that are opiates, fentanyl, Dilaudid, and then we have our adjuncts that we use, Tylenol and those sorts of things. And then paralysis. Paralysis, we have a class of drugs that are really good at that, paralytics. If we turn the volatile anesthetic all the way up, the patient won't move. But instead of that, we can have the volatile anesthetic being a little lower and then just give them a paralytic. So we can hit all of these dimensions. So now I want to kind of walk you through a case and talk about the pre-op eval, the intra-op management, and kind of talk you through what we think about from an anesthetic perspective. So here's this case. It's a 70-year-old man, and he's presenting after a fall, and he has a femoral neck fracture. So it's an old man who fell at home and has a hip fracture. And he's there with his son. At baseline, he walks with a walker because of a stroke. So you're not really sure what he does because he has this stroke that prevents him from walking around. And you are there, meet him in the ED, you're about to introduce yourself, and then ortho walks in the room, pulls the drapes open, and says, "Let's go." So are you comfortable putting this man to sleep with an anesthetic? What do we need to know before we put him to sleep? I mean, we could do a full H&P, sure, but what specifically do we care about with anesthesia? What medical conditions, what tests, what do we care about? What are we looking for? So are there specific tests you want to run? And then with any test you want to run, you want to think about, why are we running this? What are we looking for specifically? And if we find that thing, is it actually going to change our management? So with any test you order, you always want to be thinking to yourself, why am I ordering this test? What am I specifically looking for? And if I find that thing, is it actually going to change my management? Because if it isn't going to change your management, then frequently there's no real point in ordering it. One of the common things that we think about is cardiopulmonary system. The things that I most care about when I'm putting someone to sleep with anesthetic is kind of the things that are going to kill you during the surgery. And that's usually cardiopulmonary instability or airway, breathing sorts of concerns. So that's really the core thing that I care about from an anesthetic history perspective. There are obviously lots of other specific medical conditions that can really play into whether this person's dangerous. They're in liver failure, they're in kidney failure, all sorts of dynamics that can happen. But the kind of core, every single person, what I care about is how good is their heart, their lungs work, and how good is their airway? Can I get a breathing tube in them? So how good is this guy's heart? How do we normally tell how good someone's heart is? We don't do a full cardiac workup on every single person that's coming in for anesthesia, right? So how do we tell? So there's an old joke in anesthesia that the pre-op clinic, you put it on the second floor and you have a sign on the elevator that says out of order. And then so they walk up the stairs. When they get up to the top of the stairs, the door is closed and locked. And there's a sign on there that has like a little rip-off pad that says, "You're good for anesthesia." What's that referring to? So your preoperative functional capacity is sort of like a mini stress test for your heart of if you can walk up a flight of stairs, for example, walking up a flight of stairs and making it up and not having to stop and be panting. It's an okay amount of energy. And if you can do that and you're not getting angina, you're not actually, having cardiac ischemia while you're walking up the flight of stairs, you could probably do most anesthetics. If you, for example, run a marathon, that's probably a lot more work on your heart and lungs than I'm going to do during an anesthetic, hopefully. So if you can do that and tolerate it fine, you're probably going to be fine for anesthesia. So your preoperative functional capacity is really key to get a ballpark of where are you coming from. So what is this gentleman's functional capacity? Well, it's hard to tell because he had a stroke, right? A lot of these patients, for example, some of these ortho patients, they're coming in for a knee replacement. What's their functional capacity? Well, they haven't been walking around because their knee hurts. Their knee hurting doesn't tell me anything about their heart. What I care about is how much exertion their heart can provide, how good their coronaries are. So do you want to do any tests on this guy for how good his heart's working? What are the tests we could do? If we want to look at the function of the heart, how good it's squeezing, how the valves are working, we could do an echo, see how everything's going. If we want to look at the coronary supply demand, the usual thing we do is a stress test. So we have someone run on a treadmill, or we give them some drugs that make their heart beat real fast. And then we look at the EKG, see if we see ST changes. We can look on an echo and see if we see any regional wall motion abnormalities. So let's say we do that. Let's say we're not sure how good this guy's heart is. We're going to put him through a stress test, and it's positive. So now what do we do? Well, if we want to fix his coronaries, an easy thing to do is put a stent in, right? So we send him to the cath lab. They do the cath. They see, yep, he does have, stenosis of his LAD. We should throw a stent in there. They do. They stent up his LAD. But then if you have a stent just put in, you can't go for anesthesia for at least 3 to 6 months, because you're really at high risk for the stent to thrombose, and then you have a full-on bad MI. So we're going to have to delay the surgery for at least 6 months. But they have a broken hip, and 6-month mortality for sitting on bed rest with a broken hip is pretty high. So we can't cancel the surgery. So rewind time. Should we do a stress test? Well, if it's positive, we're going to put a stent in, but we can't put a stent in, so we're not going to do anything. So if they have coronary disease, if they don't have coronary disease, we're not going to do anything about it. So why get it? And if you see here, this is the non-cardiac surgery cardiac algorithm. So if you're going for cardiac surgery, obviously it's a whole different thing. We know you have cardiac disease. If you're going for non-cardiac surgery, like a hip replacement, then how do we assess your cardiac status? And you can work down the algorithm. It basically, up top, it kind of says basically, this is an emergency. Okay, just go. You're having active cardiac issues. Okay, deal with those. Then we get down to the middle, and this is where we kind of have to ballpark things. So one of the things that we do is we say, what's the risk of the procedure? So am I cutting a little skin tag off? There's no workup necessary for that kind of surgery. Just go do it. This comes up a lot with glaucoma. For the phacos that we do, it's just such a small surgery. Just do it. You don't even need a pre-op for that. On the other hand, so we have the impact of the surgery. Then we look at the person. How good of a functional capacity does this person have? So is this a marathon runner? Well, then I don't care. That's fine. But if it's a high-risk surgery and the person doesn't have a good preoperative functional capacity, or you don't know, like in this case, then we start getting in okay, now we have to look into this a little further. And if you go down to the bottom right corner here, it starts saying like, okay, if they don't have a good functional capacity and it's a big risk surgery, then you have to think, am I willing to delay this surgery? And then if you are, okay, then work up the cardiac stuff. If they have cardiac issues, then you could deal with those and that sort of thing. If you're not willing to delay the surgery, then basically just do the surgery and assume they have cardiac issues. So, for example, what's the biggest way that we can reduce metabolic demand on the heart? It comes down to, if you remember, cardiac output, which is kind of what we're targeting, is all about heart rate and stroke volume, right? stroke volume, how much the heart pumps in one stroke, boom, boom. And then you just multiply that by the heart rate, and that's how many times per minute, the volume per minute, which is cardiac output, is liters per minute. So we can achieve the same cardiac output with a boom, 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 or a boom, boom, boom. High heart rate, low stroke volume, low heart rate, high stroke volume, right? It turns out just the way that the heart works, having another full cycle of beating the heart takes a lot of energy. So low heart rate, higher stroke volume actually is a lot more energy efficient for the heart. So if we can maintain a good cardiac output, a good blood pressure with a low heart rate, that actually ends up maintaining pretty good metabolic balance. So what we do for most of these patients is just control their heart rate and just assume they have coronary disease, because unless we're going to cancel the surgery, we're not going to do anything else. Okay, so you successfully put the patient to sleep. Now they're not breathing. We should probably do something about that, right? So we usually can mask. We throw a breathing tube in. That's fine. And we'll go over the details of the mechanics of that. What if you can't? What if you're having trouble putting the breathing tube in? What if you have trouble masking? How do you deal with managing the airway? And because the airway, being able to keep the person breathing, is a really critical thing, we want to make sure we address it in an organized way. If someone's not breathing, they're not going to last very long until we fix that. So you don't want to sit around and waste time. So let's go through this scenario. Let's say you try and mask the patient and not really working. And so, okay, you say, I'm assuming you're a fully trained anesthesiologist. You go in there, take a look with the laryngoscope. It's a terrible view, super difficult. You can't get any view. You try, you maybe switch out something, you try again, can't see anything, absolutely. What do you do now? Well, the first answer in any situation like this is call for help. You might be in a situation where you have more help or not have help, but call for help. And then what do you do moving forward from that? Well, there's actually a specific algorithm we have. This is called the ASA difficult airway algorithm. And there's a lot of things on here, but I want to focus on just a couple specifically. If you notice up top, there's a lot of text, and the text basically says, make a good plan from the outset. So make a good assessment of the airway before you put anyone to sleep. If the airway looks challenging, make sure you have all the resources you need, and potentially even think about maybe this airway is too dangerous to even put to sleep. So for example, do an awake intubation where you numb up the airway and put the tube in while they're still breathing. Beyond that, you can always do things in a more sort of stepwise manner. For example, like when you paralyze someone, you obligate yourself to breathe for them, but maybe you don't know if you can, so keep them spontaneously breathing. So get them unconscious, but maintain spontaneous ventilation. Now, if we go down to the middle of the algorithm, this kind of assumes, okay, so you put them to sleep and you tried your thing and it's not working. Well, now what? And if you notice, there's this huge divide in the middle of the algorithm that says, can you mask the patient or can you not mask the patient? If you can mask the patient, then it goes to what it calls the non-emergent pathway. So if you can mask the patient, then do whatever you want. Call the anesthesia tech, have them come in, have them bring you equipment, have a friend come over. You can have a 30-minute conversation about all the different ways you could approach this airway. And it's fine because you're masking the patient. They're staying alive, you're ventilating, you're doing everything. Masking can do everything you need to do. It doesn't protect the airway, so they could still potentially vomit or something like that if that's your concern. But other than that, you're breathing for them. They're staying alive. No problem. Now, if we look at the other side, if we can't mask the patient, that is the emergent pathway. If you cannot mask the patient, the first thing that it suggests doing is put in an LMA, a supraglottic airway. Put in an LMA. If the LMA works, okay, you're fine. If the LMA doesn't work, the next step is emergency crike. Because you need to ventilate them. If you can't mask them, you can't intubate them. They only have a few more minutes to live. So, and it takes a couple minutes to cut down on the neck. So masking and being able to maintain the airway is a really critical skill. There are lots of people out there that are a little tricky to intubate, and it takes a while. There are thankfully not that many people out there who are hard to mask. So if you get really good at masking, you can keep almost anyone alive. And there are masks most anywhere. Any code cart usually has an ambu bag. You can grab a mask and a bag frequently anywhere. Intubating takes specialized equipment and it's harder. So if you're focusing on the thing that you need the skill that you need to keep people alive, masking is really, really, really the critical skill. And it's not 100% straightforward. It is a skill you need to learn. So I would really emphasize trying to learn that well. So you get the tube in, they're doing fine. So now we sit back in our chair, we crack our book, and we monitor. What are the standard ASA monitors? Now, I know we usually state this as like the specific ones, like what are the specific things we throw on every single patient? Like an EKG, a pulse ox, the blood pressure cuff or whatever, end tidal CO2, temperature monitor. So there's kind of a standard set of things we do, but the actual kind of specific definition of the monitors that we need is basically this: oxygenation, ventilation, circulation, temperature. So this comes up in areas where, for example, end tidal CO2 is a great way to make sure people are breathing. But there are lots of places in the hospital actually that don't have end tidal CO2 monitors, capnograms. It's just not one of the standard monitors everyone has. So if you're doing a sedation in an area that doesn't have capnography, what do you do? How could you possibly tell if the patient in front of you is breathing? Well, you could look at them, and if their chest is rising, you could kind of feel, put your hand over their mouth, they're breathing. You can listen to their lungs and see, there's a whole lot of information you can gather from just physical exam on the patient. So never forget that level of things. There are these monitors that we use, but it's always double check what the monitor is telling you with what you're seeing, and don't just rely on one thing, because you really just have to make sure that fundamental thing is happening. Are they actually breathing? A lot of the reason why we go with our standard set of tools is because they're really good, but they're not perfect. So now to kind of cover some of the topics that I want to talk about, we're going to take a step back from our case, and I'm going to give you a little story. So you're walking down the street and you bump into Kermit the Frog. And you say, well, hey, Kermit the Frog, I'm a big fan. And you're an anesthesiologist, so you're like, could I take a set of vitals on you? And Kermit says, sure. Great. So you hook him up, you take his blood pressure, check his pulse. His blood pressure is 15/10, and his heart rate is 5 beats a minute. And you say to Kermit, oh, that's kind of low for a blood pressure. I think I need to start an IV in you. I think we should probably start some pressors. So should we start pressors on Kermit? You ask him and he says, I don't know. I'm just a frog. Well, one thing you might be saying is, well, what's his baseline? That's a common phrase we say. What's the baseline? I don't know what the baseline on a frog is. You might be thinking, of course we shouldn't start pressors on him. But why? His blood pressure is 15/10. Well, he's standing there, walking, talking with me. So that just doesn't make sense. And so why do we care about blood pressure if I'm giving you a blood pressure that's terrible and you say, yeah, but I don't care? Because he's walking, so he's getting enough blood to his muscles to move them. He's talking, so he's perfusing his brain. I could ask him about his urine output, for example, if he's perfusing his kidneys. So I don't actually care about his blood pressure per se. I care about perfusion, right? So how do I tell how much perfusion is going on in the body? Well, it turns out that most of the organs of the body can kind of fend for themselves as long as there's enough blood going through the whole system. So what's the amount of blood going through the whole system? Well, it goes through different channels here and there, but it all goes through the heart in the end, right? So the amount of blood I'm pumping around my whole system is my cardiac output. So as long as I maintain my cardiac output, then my organs will be perfused well enough. Well, how is my cardiac output related to my blood pressure? Cardiac output, blood pressure, there's an equation for that. What's that equation? In other contexts, it's called Ohms Law. It's basically your cardiac output and your pressure. Those are related by the amount of resistance in the system. So the harder you push, the more flow you get. The more the resistance, the less flow you get. So in this case, it's the pressure, the driving pressure, which is your MAP. Technically, it's your MAP minus your CVP because it's the pressure difference. But basically, your MAP, your driving pressure through the system, is related to your cardiac output, the flow through the system, times your SVR, your vascular resistance. So the more we squeeze the vessels, the harder we have to push to get the same cardiac output. So now let's imagine we magically fix your SVR, your vascular resistance, to be normal and it doesn't change. It's always normal. So now how is your MAP related to your cardiac output? They're directly related, right? Your MAP and your cardiac output are going to go up and down just in line. That's perfect because it's actually really hard to measure your cardiac output, and it's super easy to measure your blood pressure, right? So we can just measure your blood pressure and just go with that. So now let's think through a couple scenarios. So let's say we're measuring your blood pressure, and in this scenario, your SVR drops. Like, for example, it's after induction, we give you a bunch of meds, and those meds cause vasodilation. And so your blood pressure, what happens to your blood pressure if your SVR drops really low? Your MAP will also drop. Perfect. So our MAP drops, and we push a bunch of pressors like alpha agonists like phenylephrine. We give the alpha agonists like phenylephrine, that squeezes and our SVR goes up. Now what happens to our blood pressure? It also goes up. So we drop our SVR from all the drugs we give, the vasodilators. We give a vasoconstrictor like phenylephrine. Everything squeezes back together. Our blood pressure comes back. Perfect. Now, let's say we get into some bleeding and our preload drops and our cardiac output starts dropping. Our blood pressure drops again. Now, what happens if we give phenyl? Again, to add some more squeeze. What's going to happen to our blood pressure? Well, you can think about it kind of in detail, but if we just stick with the simple model, if we increase the SVR, even with the lower cardiac output, we'll still get that blood pressure back up, right? Now, we're fixing the blood pressure with the phenylephrine, but again, I don't care about the blood pressure, right? I care about organ perfusion. So if we're bleeding and our cardiac output drops, if we give phenyl, if we give pressors, we will increase the MAP because it's increasing SVR. So I'm fixing the number on my screen, but again, I don't really care about the blood pressure, right? What do I care about? Tissue perfusion relating to my cardiac output. So I'm fixing the MAP, but what's happening to my cardiac output? Well, it's still saying low. So in both of those scenarios, my blood pressure dropped, but the treatment for those, in one case, giving some phenylephrine to fix the SVR, in the other case, optimizing the cardiac output, for example, by giving some fluids, crystalloid, albumin blood, whatever you need to give, very different treatments for the same symptom. So how do we tell the difference when the blood pressure drops, what the treatment is? Well, you have to look at the context, basically. What are you guessing the current SVR is? What are you guessing the etiology of this blood pressure change is? And then you have to guess correctly. What happens if you have a really sick patient where it's kind of hard to tell? Their cardiac output could be varying because their heart's not so good, and their SVR could be varying because of all the drugs we're giving, and we're not sure how vasodilated they are. Are we underfilled? Are we overfilled? It gets very complicated. What do we do in those cases? Well, we need a more direct measurement of their cardiac output to be able to optimize their cardiac output. So we put in a cardiac output monitor. So we'll put in a PA catheter that can directly measure cardiac output. We'll put in a TEE, a transesophageal echo, so we can watch their heart and approximate their cardiac output and their function through that. So I hope that makes sense. What I wanted to emphasize there is basically we measure blood pressure, but don't just think about the blood pressure as a number you should fix. Think about the whole system. You're trying to optimize cardiac output and tissue perfusion. Make sure you don't just focus on the number, the blood pressure. That's how people's fingers get black and fall off in the ICU, because we're just increasing the SVR. You can fix that number, but fixing the number doesn't fix tissue perfusion. So now that's the cardiac system. We're going to move on to the pulmonary system. And again, kind of a thought question to start out. When I hold my breath, I don't desaturate very quickly. In fact, I've tried this. I don't think I can hold my breath long enough to desaturate. You can try it yourself. Put a pulse ox on yourself and try and hold your breath. I can't hold my breath for that long, but it's really hard to desaturate. So now, bear with me. Another thought experiment. Let's say we take someone. They're sitting there. We have a pulse ox on them. They're 100%, and we instantly stop time, do a sternotomy, and we take their pulmonary artery and pulmonary vein and tie them together. Take their lungs completely out of the system, and put their chest back together. Restart time. What is going to be their pulse ox after the next heartbeat? Well, how do we figure this out? So where the pulse ox, that's the arterial oxygenation, and we're saying so it's starting at 100%, but the next heartbeat, a next poof, rush of blood that's coming. Where's that coming from? That's coming from the aorta and coming out of the left side of the heart, right? Left ventricle pump. And normally that's filled from the lungs, but we've cut the lungs out in this case. So where's that blood going to be coming from? Well, I said we tied the pulmonary artery and pulmonary veins together, right? So instead of that blood coming from the lungs, it's going to be coming from the right side of the heart, right? So after one heartbeat, or let's just say two heartbeats just to cover our bases here, what's that blood is going to be coming from the right side of the heart and then pumped out into my arteries, right? So what's the oxygen saturation of the blood in the right side of my heart? Well, that's my venous blood, right? So what's my venous saturation? Now, that might sound kind of like a weird question, but we actually measure it. If you put in a central line into the right atria, we actually measure that oxygen saturation sometimes. It's called the central venous saturation. And particularly if you work in the ICU, it's something we use. So what is that value? In a normal person, it obviously varies, but it's around 70, 80%. So if you cut out your lungs and after a heartbeat or two, what's your sat going to be? Well, it's going to be your venous sat, right? That's where the blood's coming from. So very, very quickly, your sat's going to drop from 100% to 80%. So why doesn't that happen when I stop breathing? Well, the obvious answer is I still have my lungs. I'm still oxygenating when I'm not titling, right? If I'm still oxygenating when I'm titling, why do I need to title my lungs at all? Why don't I just sit here and not breathe? Well, the titling, our breathing in and out, that has to do with getting rid of CO2. Oxygenation, the oxygen getting into our blood, that's a continuous process. That happens constantly, whether I'm breathing in, whether I'm breathing out. If it wasn't happening constantly, I would desat really quickly. And we actually see this in practice too. It's a shunt. So for example, if you have someone with a very large atrial septal defect, if they cough, instantly their sat drops to in the 80s because they're shunting all this venous blood over to the arterial side. So oxygenation is a continuous process throughout the breathing cycle. CO2 ventilation has to do with pumping the CO2 in and out of the lungs. So you might ask, okay, I believe you, but I mean, CO2 and oxygen are both gases and they're both going in the same lungs. So why are they different? Why doesn't CO2 constantly move? Why difference? So one more thought experiment. So when you're in the ORs, look at the anesthesia machine and it shows you the FiO2, the inhaled oxygen. And it also shows you the FeO2, the exhaled oxygen. And let's say the FiO2 is 50% and the exhaled oxygen is 45%. So one of the things we're talking about now is, cost, efficiency, and those sorts of things. So we're giving people 50% oxygen. They're breathing out 45% oxygen. And that exhaled gas is just being exhaled into the environment. That's a huge waste. They're only consuming 5% oxygen, right? So let's just set their FiO2 to 5%. They'll breathe in 5%. They'll breathe out 0. And perfect efficiency, right? Sounds like a great plan. You actually can't do it because the machine won't let you turn the FiO2 down that low because it's so dangerous, because they're going to desat like crazy. Why? Why do we need to be giving them all this oxygen that they're not even using, right? So it relates to the same reason why we use CO2 in our sodas. I guess it'd be interesting to have an oxygen soda. That'd be kind of cool. But you can't. Why? Because oxygen doesn't dissolve in water. CO2 dissolves like crazy in water. For example, this is in blood. In blood, you can dissolve 500 cc's of CO2 in a liter of blood. It's a huge amount of CO2. Oxygen, in the same liter of blood, you can only dissolve 20 cc's of oxygen. So oxygen is very insoluble in blood. CO2 is very soluble in blood. Think back to the oxygen content equation. It's like something, 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 hemoglobin, your saturation, and then plus really, really, really small number times your PaO2, right? You remember what I'm talking about? It's like the oxygen content in your blood is all about your hemoglobin, because your hemoglobin's your oxygen carrier. And then there's dissolved oxygen, but it's such a small number, we don't really care about it. It's because oxygen doesn't dissolve in blood. That's why we need hemoglobin. So when we're talking about getting oxygen into blood, it's all about getting an insoluble thing into that liquid it doesn't want to go in. CO2 is all just a numbers game. It dissolves fine. It gets out of the blood fine. We just have to crank through the gas because we produce so much CO2. So CO2 is all about minute ventilation, your tidal volume, your respiratory rate, how much air you can get through your lungs as fast as possible. Oxygen is about a solubility problem. So think back to basic chemistry. We have this, semipermeable membrane. We want to try and get something to cross it. What are the factors that are involved in how much we can force across this membrane? The things that I remember are concentration gradients, surface membrane properties, and surface area of the membrane. So what's the concentration gradient we're working with? Well, it has to do with the amount of the concentration of oxygen we're giving them, right? So the reason why we need to give them such high concentrations of oxygen doesn't have to do with the amount of oxygen they need, they're consuming. It has to do with the concentration gradient to try to drive it into the blood. So we need a high concentration of oxygen. So FiO2 is one of the things we can change to try to increase our absorption of oxygen. So what membrane characteristics, it's kind of hard to change those things. We can avoid damaging those things, like avoid pulmonary edema, avoid ARDS, avoid damaging the lung itself. There's not a lot we can do to fix it a lot of times. What can we do to change the surface area? The lung alveolar area that we're absorbing over. Can we make the lung bigger, smaller? Well, sure, right? We can inflate the lung. Some of the lungs, some of the alveoli might actually be collapsing at atelectasis. We can pop those open. We can change the actual kind of size that we're inflating the lung, and it stretches a little bit. So the lung volumes that we use can actually increase our oxygenation. So one of the things that you might think of how to increase oxygenation is FiO2 and PEEP. So why does PEEP increase oxygenation? Well, just like with the cardiovascular system, we measure something that's a proxy of something that's harder to measure. In the pulmonary system, we don't always care so much about the pressures that we're driving into the lung. What we care about are the pressures inside the lung and the lung inflation. And assuming a certain compliance of the lung, we can say that the lung pressures have to do with the lung volumes. So if we increase the pressure, we're increasing the size of the lung. And the bigger the lung gets, the more surface area we have to oxygenate. So we want to keep pressures higher in people if we want to oxygenate better. You can do that through increasing the PEEP. You can also increase the inhalational time. So instead of going with a short inhalation and a long exhalation, an I to E ratio where the exhalation is long, we can shorten up that I to E ratio to be 1:1, where they're breathing in and exhaling at the same time, or inverse ratio, where you're actually holding in breaths. That increases the oxygenation kind of to the maximum we can. So inverse ratio of ventilation, where we go, it's a very weird way to breathe, but we can do that in people with, for example, ARDS, where we're really having trouble oxygenating them. We just keep their lungs open as long as we can, because again, oxygenation is passive. It doesn't have to do with titling the lungs. Now, when we do that, their ventilation, their CO2 transfer does suffer, but we're trying to trade off. Most people can tolerate a little bit of hypercapnia, but they tolerate less well hypoxia. So we're trading off the hypoxia, hypercapnia. And in the end, we go through the case, you manage the oxygenation and blood pressure and everything beautifully, and he survives. It's wonderful. Like I said, I'm trying to introduce the concepts to you, talk through some of the kind of academic theory part of this. And then what I want you to do, think about this, think about the scenarios, think about how the body's working in these contexts. And then we're going to play around in the sim session working through some of these scenarios. What will you actually do? How does it work? How's the body going to respond? So I hope this was helpful for you.